buprenorphine for a pain management and RN care managed approach. Thank you, Katie. Take it away.
All right. Hi, everyone. This is kind of a full set of slides. I hope to get through to a point where we can talk a little bit afterwards. So next slide, please. The fundamentals of care, we call it opioid stewardship. This is from the stewardship handout. I just wanted to start with this. Fundamentals of care include informed consent, assessments, cures monitoring, which is now required if a patient is on more than 90 morphine equivalents of opioids per day. Narcan care, opiate use disorder management, which starts with assessing and diagnosing for opiate use disorder. And there is a link for the rest of that very handy little booklet. Next, please. So what we're going to talk about is very specifically the care of patients who kind of fall through the cracks. And this is more about pain management than opiate use disorder. But as we all know, these diagnoses, these comorbidities intersect a lot along with the complexity of treating chronic pain. So we begin with the biopsychosocial assessment and care for patients with chronic pain. This is a great quote: "A good physician treats the disease. A great physician treats the patient who has the disease." And the pearls and pitfalls, this psychosocial context of chronic pain suggests a close relationship between a patient's emotional state and his or her chronic pain experience. Negative emotions can increase the perception of chronic pain, whereas a positive emotional state can lead to a more favorable therapeutic response. This is the context of our care, is making sure that that whole person has their emotional support along with their physical and mental support. Next, please. I gotta move this. A few things to consider. Stigma of Suboxone. When in the emergency room, when cures are checked, when working with specialist providers. So a lot of patients now are receiving scripts for Suboxone to manage their pain who actually do not have a diagnosis of opiate use disorder. They have opiate use dependence. But when they go into these other settings and the med list says Suboxone, there's an assumption, and I've heard from multiple people about this particular form of stigma. Suboxone itself now carries a stigma, and they often are treated with disrespect and suspicion. And we need to be aware and educate, and also, if at all possible, use buprenorphine only rather than the combo med of Suboxone. When treating pain with buprenorphine, a waiver is required, a misspelled waiver. So if there's just a pain management issue that is occurring here with the patient, then no waiver is required. If there's comorbidity of chronic pain and opiate use disorder, then prescribe Suboxone. And once you're prescribing Suboxone, you need to have that opiate use disorder diagnosis. The concerns and fears of our patients are valid and must be respected. We partner with our patients with the reassurance that we will make these changes safely and comfortably. This is probably one of the greatest challenges is for our chronic pain patients as they get caught up in the sweeping changes around opioid prescribing, and having this caring relationship is essential to making changes that may get them to a better place. And always integrating cultural and traditional community engagement and support is essential for patients living with pain. Often people living with pain are elderly or disabled, and there's just a natural isolation that occurs, physical isolation, and also the loneliness of feeling pain. Next, please. So there are 3 pathways of care for patients with chronic pain. Medication-assisted treatment for chronic pain if there's now a co-occurring opiate use disorder. The way that you identify that is you can use the DSM-5 opioid checklist, looking for behaviors such as misuse, turning to injectable opioids, or diverting. So if there's opiate use disorder, the chronic pain patient can now receive care for both of those diagnoses in your MAT program. The second one is SafeRx for patients who are prescribed opiates for chronic pain where there are concerns about opioid dosing. What I mean by that is there's self-escalation, there's early running out, there's something going on with the dosing where the patient's not able to take as prescribed. Drug combining, and drug combining would be with benzodiazepines and other medications, methamphetamines. Other substance use disorders such as alcohol and untreated behavioral health diagnosis. So the SafeRx patients often we're going to look at, we'll see cocktails of maybe 2 prescribed opioids, a benzodiazepine, maybe Soma or one of the bedtime Z drugs. So often there's a combining of drugs that requires some investigation is if this is safe, is this effective, and do we need to make changes? And the last one is buprenorphine for pain management. And this is really for patients that have no or mild opiate use disorder, but poorly managed pain. And that is really primarily going to be our discussion today. These folks often get lost in the shuffle, so it's important to identify if there is an opiate use disorder or if there is a safety issue, then you would send them down a different path. Next, please. So frequent and common problems, the lack of provider time to support change, the 20-minute appointment for providers in our clinics tends to be a culprit in when we wanted to start shifting our patient towards healthier solutions for pain management. Patient anxiety and resistance to change. This fear can be expressed as anger and aggression. This is crucial and needs to be addressed initially so that we develop a partnership for change with our patients. The T word is, the taper word is often a very scary word because patients have a fear that they will have withdrawal or that they will have poorly managed pain. I don't think we really need to use the taper word very much. We're going to switch. Other undiagnosed substance use disorders, often this shows up in the annual drug screen or the every 6-month drug screen, whatever your clinic does. And it's important that it gets pulled into the picture so that we can provide comprehensive care. And co-occurring behavioral health diagnosis. Major depression is very commonly seen with chronic pain because it is really a difficult adjustment for a human being to live with pain. And the other medications, as mentioned earlier, the sedatives, the hypnotics, the benzos for general anxiety disorder, and the Soma especially. So these are common. We all know as I'm talking that we all know these patients and the challenges of getting them to optimal wellness. Next, please. So why buprenorphine? This is from the Pain and Addiction presentation by Dr. Andrea Rubenstein at the California Society of Addiction Medicine. So it is the safest opioid. It is anti-hyperalgesic, acts as a chaperone ligand. Doses can be stable and can decrease over time. Available now in both very low, and high dose. Lower abuse potential. Buprenorphine is a Schedule 3 as opposed to the Schedule 2 full agonist opioids that are prescribed for pain. And it does not block analgesia from other opioids. Well, it does a little bit, but not completely. So there's a lot of points here about why buprenorphine for pain management is a good option. Next, please. So I'm going to talk about the patient pathway. And this is what I was doing in my clinic at Chappaday and also doing at the VA many years ago. The provider refers to the RN case manager. And the first thing that I would do is a complete assessment. There's a Bup for Pain template that comes with this. So Jeff will be sending that out. Kind of the whole process of assessing and planning. The next thing is education, teach about buprenorphine. This is crucial. Patient really needs to understand what the medication, how it will be different, what it has to offer. So make sure that you take the time to educate the patient about buprenorphine. And then some planning. And planning involves working with the provider as to when the patient is going to start. And there's also a Bup for Pain patient instructions, which is very specifically about withdrawal management. There needs to be an episode of no full agonist opioid in the system and in the brain so that buprenorphine can claim those receptors without the downside of precipitated withdrawal. So the Bup for Pain handout will also be available. And the other really crucial part of this extra care, and it doesn't have to be an RN, maybe the provider has an MA that can manage this, the stabilization, is the first days of phone monitoring and 1 week follow-up. Getting that patient as comfortable as soon as possible is crucial. Next, please. So if there's opiate use disorder, and we really want to explore this right away, if opiate use disorders behaviors are identified in assessment, explore the severity with patients. The continuum of mild to moderate to severe for opiate use disorder, as described in the DSM-5, is extremely helpful. Often we won't see, the only place that we will see what we would call mild opiate use disorder is those patients who have been on long-term opioid therapy for their chronic pain. And the mild version would be maybe self-escalating the dose on pain days, or hoarding them is a very common behavior, hoarding the pills. So any kind of change of dose kind of points to a mild version of opiate use disorder. Is the opiate use disorder primarily driven by the need for pain relief? That is a very essential question. Explore directly with motivational interviewing, explore ambivalence and fears. And will this patient do better in the MAT program? And address the stigma. Everyone treats me like a drug addict. We hear it way too frequently in our world. So that stigma causes a lot of defense and anxiety. So an open conversation with our patients is essential and ultimately builds that effective partnership that we're looking for, that healthy autonomy. Next, please. So the RN workflow, and I base this on my own experience. You know, I'm an addictions RN, and but there are other staff, LVNs or MAs, who may be able to take on this piece. So the patient is referred to me. We do a full assessment. We make a plan. The patient gets educated. I discuss with the provider the dosing, how it's going to go, and then we will start the buprenorphine, and I will follow the patient. Usually it's up to 3 appointments with the RN case manager. So week 1, week 2, and week 3. Sometimes if they're struggling with getting a stable dose in the first few days, I will have them come in and see me. So the RN also is responsible for the assessment, the education, the ongoing discussion with provider for plan and monitoring, and addressing co-occurring substance use disorder, which often with chronic pain patients is alcohol use disorder. And I manage the plan for buprenorphine start, including any needed opioid conversions and the withdrawal phase. Real quickly, an opioid conversion, for example, we may have a patient who is getting something like MS Contin, 30 milligrams twice a day, a secondary short-acting full agonist opioid for breakthrough, let's say Norco 10. Before we switch to buprenorphine, we're going to want to make a conversion. The provider will want to make a conversion where that long-acting full agonist is converted to short-acting, and then maybe a week of that, and then the brief 24-hour abstinence from the short-acting opioid will prepare them for buprenorphine. If you have any questions, please send me notes about that. It's pretty easy to do and really keeps the patient as comfortable as possible. Next, please. So the workflow includes the first days of the start, managing dose changes, see patient the first few days as needed, follow up with RN in 1 week. Once dose is stable, then schedule follow-up visit in 2 weeks with provider. So the patient is now all buttoned up, hopefully, and ready to go back with a whole new pain regimen to their provider, and the provider takes it from there. The ongoing care is now with provider, and the patient has established a relationship with the RN and can call as needed. This is a really very effective use of RN or LVN time to get these patients back on track and not low demand on provider time. And our job in the clinics is to utilize provider time as efficiently, as effectively as possible. Next, please. Treating the co-occurring substance use disorders. They must be treated. Once we have a diagnosis of a substance use disorder in our patient's problem list, we really need to begin to identify how we are addressing it rather than just having it sit there because we're not comfortable addressing the other drugs and alcohol that they may be using, especially if there is additional use of alcohol and benzodiazepines. Very common phenomena in the last 5 years when providers were encouraged to really decrease and taper opiate dosing for safety. A very common behavior with our chronic pain patients was for them to begin drinking more, especially at night as they are responding to their pain and their inability to sleep. So often there's this hidden additional problem that is intensifying in severity. So there may be, when the RN meets with the patient to plan for buprenorphine for pain, there may need to be a detox, a residential detox, Last year, I think we sent 4 people into residential detox before we started them on buprenorphine. And because their pain relief was so significant, they managed to stay sober. So if a benzodiazepine, assess for slow monitored taper, or convert to Librium if benzo dose is high or misused. The benzo thing needs to be considered very carefully if you're switching from your full agonist opioid therapy to buprenorphine, and there needs to be a plan if there's any safety issues involved. These patients will probably be more the safe RX pathway of care. Monitor with weekly urine drug screens of an early recovery and keep the pain well managed. And if there's stimulant use disorder, which we also see in our chronic pain patients, they also may need to go into treatment in whatever level of care that they would be identified as needing. Next, please. Switching to buprenorphine, it kind of looks like this. So this is a basic Christina Lasich rule of thumb protocol. Start with the Butrans patch. It's a 7-day patch, depending on the dose of opioids. The Butrans is a wonderful delivery system for buprenorphine for pain management because it's an even steadier state than the sublingual dosing. We would often start with the patch. The patch comes in 5 micrograms an hour, 7.5, 10, 15, and 20 micrograms per hour. So there's a lot of doses. Very hard to do a direct conversion with that, with the patch. And we use the sublingual, which is off-label, to manage withdrawal and then find the best dose for pain management. Dr. Lasich's rule of thumb protocol is if it's less than 40 morphine equivalents, start with 2 milligrams twice per day. And between 40 and 90, start with 4 milligrams twice per day. Equal and above, start with 8 milligrams twice per day. Often patients, especially on the lower end of the morphine equivalent, will be fine with actually 1 milligram twice per day in my experience. So it's going to be very important that we find that right dose for maximum pain management and minimum side effects. Most importantly, the discussion of expectations is most important, like the fact that buprenorphine takes some time, get up to full speed, and thus immediate full results are not to be expected. That's from Dr. Christina. Next, please. Starting opioid naive patients on buprenorphine for pain management. This is a trickier patient, but often quality of life really, this can be very life-changing for patients who are no longer on opioids for whatever reason, or now have a new pain syndrome and they have not started on medications. These are not uncommon patients. Since there is no withdrawal to treat at buprenorphine initiation, we can expect the patient to be more sensitive to side effects. This is really crucial. And I've seen it with patients who have opiate use disorder who have requested to start buprenorphine, and maybe they have 2 or 3 months of abstinence from all the opioids of choice, and they feel like they're gonna do better if they're on buprenorphine. So more sensitivity to side effects in the initial phase of starting buprenorphine. Educate the patient that once we know more about any side effects, then dose will be adjusted to manage pain. Common side effects, what we're really going to look for is nausea, headache, sedation, and these side effects can clear up in 3 to 7 days. These patients will need to be started on the lowest doses. Usually we use the lowest dose of Butrans or buprenorphine tablet, 1 milligram SL. So we'll take a 2 milligram tablet and cut it in half. As long as the complaint side effects persist, do not escalate dose, even if the pain is not yet well managed. So if you're moving somebody from a full agonist opioid over to buprenorphine, and you have to take that short phase of withdrawal, which can be really short if you use Butrans, but there is a phase of withdrawal to be expected. The nurse and the provider are going to focus on getting through the withdrawal. If it's a naive patient, you're going to focus on getting them through the side effects. So you got to look at this with a couple of different sets of eyes. Next, please. Okay. So this is kind of what I have learned about benzodiazepines in my many years of working with benzo dependence and benzo use disorder. So if you're tapering the benzos, you're going to want to consider converting to Librium or phenobarbital, which is what we did in the old days. Now we use Librium. You can pull up this benzo calculator, and it will tell you specifically, let's say, for example, the patient is has been taking alprazolam 2 milligrams 3 times a day. So that's 6 milligrams. You're going to convert that directly to Librium. It's really helpful to separate the patient from that long preferred benzo. It's kind of like breaking up a romantic relationship. The attachment to the benzo is often complicated and difficult for the patient to let go. So converting to the Librium keeps them comfortable, and then tapering slowly contributes to the concept of making a change. So without feeling any change in what they experience with their benzo, they are now experiencing that with a different benzodiazepine, and must do this on a weekly, these must be a weekly RXs until the patient feels confident and committed to this change. This is an essential approach to tapering benzos. If you guys out there are doing other things, it'd be great for us to share. But I have utilized with my many providers this approach, and patients are deeply ambivalent about being separated from their benzos. They feel stuck, they feel worried, they have more anxiety, they're fearful to discuss. So finding that place in them that's motivated for change is an essential part of the partnering with their decision to make the change. And you can take your time with the Librium. I had a patient, I think, who was tapered slowly on Librium over 6 to 8 weeks, did really well. Okay, next one, please. Oh, a few more things to discover. Let me move this thing. A few more things to consider. Some providers will add a full antagonist to buprenorphine for pain. For example, Dr. Lasich, who I quoted earlier, will use additional tramadol if the pain is difficult to manage, and if there's low risk. So I would do this with great caution because they're back in that full agonist world again. But for some providers, this is working in the context of their relationship with that patient. short RXs initially, then as patient stabilizes and no concerns about misuse, then monthly supply. Buprenorphine for chronic pain diagnosis accepted by Medi-Cal. We never had a problem with our B-Trans orders or our sublingual buprenorphine orders for pain management. Next, please. Whole person care. So we have Dr. Mark Goodwin at Sonoma County Indian Health Project presented on pain management at the Paula Crib Opioid Summit in December. It's an excellent set of slides. They have a really beautiful program that really utilizes yoga and chiropractic care and acupuncture, cultural support. So we will be making his slides available on the Telewell website. I highly recommend that you take a look at what he has to say. It's just comprehensive and really detailed. We want to offer behavioral health care, especially if we're looking at depression, chronic anxiety, especially if benzos have been part of the picture. Support groups, really, if you can't start with all of those other specialties, establishing a pain support group can be marvelous. At our clinic in Auburn, Day, we had a very connected and caring pain support group that meant a lot to the people who were attending it. Then there's always the procedures, the injections, the joint trigger point, the epidurals, referrals to pain clinics, neurosurgery, orthopedics, PM&R, ice and heat, movement-based therapies. Physical therapy is often something that a patient may dread but get tremendous benefit. And the next please. So there, right there, these are my resources that I'm recommending. The opioid safety, which is Dr. Goodwin's set of slides. Dr. Robert Frey he's really a gifted pain doctor. If anyone has seen him, he contracts with Crib and does some telemedicine with some of the tribal clinics. He has a website that I would encourage you to check out. And if you ever hear that he's going to be giving a talk, make sure you make it, because he's a lot of fun and very educational. The Mayo Guide to Urine Drug Screens is comprehensive, excellent, and really excellent guide to urine drug screens in terms of patient care, including false positives, false negatives. They've got some great tables in that article, and I encourage you to go look for it. And Caring for Patients with Chronic Pain, the Pearls and the Pitfalls is often talks about a lot of the psychosocial challenges that we encounter when we're treating patients with chronic pain. And one more slide. So there's a few more things. Dr. Lasich, she doesn't have a website, but I put her up there anyway. Drug Dealer MD, Dr. Anna Lemke has great materials in buprenorphine for chronic pain, a review of clinical effectiveness, and Dr. Rubenstein's presentation at CSAM. If you want some help finding those resources, just send me an email and I'll try to dig something up for you. Really excellent contemporary pain teachers right now. And with that, I think we have some time for questions. Feel free, you can, if you wish, you can Unmute your mics, ask questions. Anybody? Any thoughts? Any arguments? Silence.
Are you able to see the chat? Katie?
Oh, okay. So I'm looking at the chats. Hi, Jim White. Would like to know more about the conversion. Yeah, we can. The conversion is basically what you want. The fundamental concept around converting the opioids in preparation for switching over to buprenorphine is that you want the patient on short-acting opioids only for 5 to 7 days before they stop completely and start the buprenorphine. So, and you can just convert it. You can just pull up the opioid morphine equivalents. You don't even need to taper the patient. Just make sure that they're on a short-acting opioid before they start the buprenorphine. Does that help? Alrighty. Do you find the butrans patch has the same issues as a fentanyl patch? Not at all. The butrans patch is actually a very low dose. So if you're going to compare apples to oranges here, fentanyl, of course, is a very potent full agonist opioid. The butrans is a very low dose, long-acting version of a partial agonist. So not that similar and very, very safe. The butrans is very safe, where the fentanyl patch is it's for pretty severe chronic pain, but it's very risky for opiate use disorder. Long-acting agonist to short-acting. Okay, any more questions?
So I will go ahead and unmute anyone's microphone that would like to speak. So just go ahead and raise your hand and I will unmute it. There are a couple more questions I see in the chat right now.
12. Oh yeah, we have time. So
Can you hear me?
yeah, is that Jim?
How you doing, Katie?
Hi, it's good to see you.
You too.
So tell me more specifically your questions about converting.
So once you convert from the long-acting to a short-acting for 5 to 7 days, do you then treat them like a MAT patient temporarily to get them through the withdrawal state and then titrate the medication for the buprenorphine for pain medicine, for pain control?
Yeah, it's very similar. The patch makes it possible to, let's say let's say that you have switched both your short-acting and long-acting opioids to an equivalent morphine immediate release. And then you have the patient stop, usually you're going to want a 24-hour period of abstinence to avoid any risk of precipitated withdrawal, but you could probably put the patch on at about 12 hours without it causing precipitated withdrawal. Does that make sense? So you convert it, so you don't have to taper. You can just convert to short-acting, keep them on short-acting, and then make the switch.
So once you make the switch, there's potential for precipitating withdrawal, though, right?
Not if you give them 24 hours with that. I'm using the example of morphine immediate release. So you stop that on Sunday night, and you start the Butrans maybe in the afternoon of Monday, and you're going to know very quickly if there's any kind of precipitated withdrawal, but you probably won't have it. And as time goes by, the chances of precipitated withdrawal decrease hour by hour by hour. The big conversion would be methadone to buprenorphine, and that's a more specific switch. But if you're switching a short-acting full agonist opioid to buprenorphine, it can be done pretty easily in 24 hours with very low risk of precipitated withdrawal.
All right. Yeah, that does answer my question. Thanks, Katie.
All righty. Anyone else?
Katie, can you hear me?
Yeah. Hi, Iris.
Hi, Katie. Good to see you. See, I have a couple questions, and based on the presentation that we attended on the alternative methods of Reiki and yoga and acupuncture, I did want to go back and see if there was more information on acupuncture. And then I had a couple questions from elders, healers, that were wondering, is there anything that they should be aware of in taking anybody using any kind of medication into the sweat lodge? The heat and, you know, those kinds of things. Is there anything that they should be aware of?
Well, those are several questions. So that would be the sweat lodge is the bigger question, right? Because of the safety, and that would be really up to the provider. And we're talking about somebody who is taking buprenorphine for pain, correct?
Yeah.
Their doses, their doses of buprenorphine are going to be a lot lower than any opioids. So they're already into safety, significant leap into safety. But I'm not going to say just everybody can go get into a sweat. There's always going to be co-occurring other conditions that need to be reviewed with the provider. So.
Yeah, I think their questions were around any heat sensitivities that they should be aware of.
Not really.
Okay, thank you.
Yeah. It depends on the dose. It's very hard just to make an absolute statement here, but I would definitely say ask your provider about it. But if you're looking at the safety of a full agonist and the safety of a partial agonist, that buprenorphine is so much safer.
Okay, thank you.
All right, thank you. And did you want to talk a little bit about the Reiki and the traditional healing? Anything about that?
Well, I just thought that was one of the most powerful presentations that I've participated in, and I think it was because the presenters were able to make those very clear, holistic links to the whole person, which makes a lot of sense. And particularly the yoga, I thought that was one area that I wish there was more of it across Indian country. And I think that it might expand based on some of the work that we're doing, just educating people, and then the encouragement by the certified providers for people to become certified, to learn about the method. And what better way to be able to promote something than for yourself to be knowledgeable of what that approach is. So I have really taken that to heart, and it's become a part of conversations and resources that we're sharing with tribes.
Well, yeah, that is a really good direction. I've been involved in energy healing for about 40 years. I'm very familiar with Reiki and yoga and mindfulness approaches, acupuncture. Those are for just personally my preferred routes of healing. When we get into the world of medicine and the clinics, often the obstacles are how do we bill for this? How do we pay for this? And so the Indian Health Council team and Dr. Goodwin's team are really, really doing the essential work of bringing that into their pain programs. And I'm as excited as you are by it.
Yeah, thank you.
Yeah. Yeah. So when I talk about buprenorphine, that's one small, tiny part of the person care. And I'm really glad that Iris brought this into the center of the conversation. Anyone else have comments, questions, clarifications? What I think that's been essential in my work with helping people get off of the full agonist and get into healthier lifestyle with buprenorphine is the fact that I can offer that extra time, that extra care that the providers cannot. The nurses, if you have a skilled, trained nurse working with opiate use disorder and chronic pain, we bring the gift of time because we're not billable. RNs are not billable, LVNs are not billable, but we can spend time and really make that pathway to better health for our patients very smooth and well managed.
It looks like we have a question in the chat about Butrans with the heat of a sweat lodge.
Well, the Butrans patch for some people is problematic because it's transdermal. And we use something called Tegaderm, which is that really clear, really sticky adhesive that you'll see it in, when people have IVs. And so we do a Butrans, we actually just give them Tegaderm to protect their patch. And the heat of the sweat may really challenge that Tegaderm, but that's a good way to go. Remember that Butrans is a very low dose of buprenorphine. I don't know if it'll increase the absorption rate. I don't have an answer to that. I'm not that familiar with, yeah, you would probably know more than I do, Coco. Anybody know anything about a buprenorphine patch in the sweats? Anybody out there? Don't see it as a problem. Always check with your provider. Okay. I think we may be done. Anything else, Jeff?
No, that was a terrific presentation. 12:56, right on the dot. Thank you so much for giving this presentation, Katie. That was really good. I learned a lot. And thank you everyone for attending.
Thanks for attending. You know where to find me if you need me and need more information.